You're listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years of EMS experience. Each month we discuss EMS news, medical science, and review actual EMS calls, offering many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome everyone back to the Medic Materials Podcast. I'm joined here with Emily as always and Kelsey here too. Yay, hi. Yay. So one thing we are missing though is our resident paramedic, Gerardo. He is actually going to be taking a leave from the podcast for a while. He didn't actually tell me how long, but what I need you guys to do is if you miss him, love him, want to send him a message, go on the old Facebook at Medic Materials EDU, send a Facebook message, or you can email us at info@medicmaterials.com and just send us a little thing like, hey, we love Gerard. We want him back, but we
send him a meme. He loves them.
Oh my God, he loves
memes.
them. Send the memes, and I will forward them to him. It'll make, as Kelsey says, his heart happy. And yeah, we'll just hope that he returns in a quick fashion. But for that, he actually said, or one of you girls said, I don't remember, said that his seat is now going to be called the hot seat until he returns. And we filled the hot seat with one of my friends.
No pressure.
He's a fellow EMT that's going to be joining us for today. Matt, hello, welcome.
Hello, everyone.
I am going to let you introduce all of your certifications because I'll probably fall asleep by the end of when you're done.
So
we'll be back in 5.
Like as you said, I'm an EMT basic. I've been that since 2014, 2015. But I've been a firefighter for longer, so that's where a bulk of my certifications lie. I am the chief of a local fire department. I'm the chief of a local EMS agency. I run EMS at another agency in the area. I recently passed my certified instructor coordinator exam for New York State. Yes. So and I can get out and officially do all the things that I've been trying to do for the last 5 years. I was hired as a state instructor for the fire service back last year. So I've been doing that. Recently got my fire instructor 2. So I'm actually certified to write lesson plans as well, which I have no intention of ever doing.
Oh, come on. You could have so much fun with
You
that.
could have so much fun.
I could, but I work for the state. So,
So probably not.
My views do not necessarily represent the views of the state of New York.
And you went to nursing school.
I am currently enrolled in nursing school, yes. So I have not actually taken any of the nursing classes yet. I'm what we would call a nursing pathway at this point. That's going to take some time. I have 3 little ones at the house that need care, and yeah. So.
Yeah. All right. Well, with all of that experience, we're going to throw you right into your first call review here. So,
my experience is all educational, bud.
That's
like the field experience.
Hey, you took care of me when I passed out that one time.
What's an ambulance? I'm theory, man, not practice.
Well, you'll get a little bit of both today.
Right, cool.
All right. So we're going to start the call review today. This was actually a call that Gerard wanted to present, but since he is taking his leave, we're going to carry on and present it anyway. So standard EMS system, one transporting ambulance staffed with an EMT basic and a paramedic. So 2 provider crew. Your local hospitals in this area, you got a generalized local hospital 20 minutes away from the scene and a large urban medical center approximately 35 minutes to 40 minutes away from the scene. Okay. It's a fairly rural residential neighborhood, and your dispatch priority 1 or a Delta priority to the local urgent care for a 71-year-old male with difficulty breathing. Anybody have any thoughts on urgent cares before we start? Get them all out on the table now. They suck.
Just go in with a clear mind. Don't listen to them.
I think you have to listen to a point. Like
But
you have
keep
to
your
take
mind
it in,
clear.
but you have
Don't
to,
let that shade your judgment
Right.
because they've already made a decision on this and it doesn't mean it's right.
Yes. Yes. We'll go with yes.
The very first call that I ever ran on the ambulance, this was back during my clinical time, was to the local urgent care. We were dispatched for a male who was hyperventilating. That was it.
Or to Kipnick because they're DKA. No big deal. It's fine.
So
It's fine.
we get there and his blood sugar is high.
Yep. See? See?
It's almost like you knew this story.
He's not just tachypnic. He is at 40.
Just hyperventilating. Relax.
And as
Give
we
him a
are-
brown
Give
paper
him a brown-
bag. He's fine.
Well,
Send him out.
so we're trying to, and the nurse is saying,
They
"We've
try the
got him-
paper bag?
We have him on a nasal cannula at 6.
Oh, yes.
And
Love it.
me,
At least it wasn't a
not
non-rebreather
knowing-
at 6.
I know
That's-
shit about
that's
shit
accurate.
at this point. All I know is I'm gonna bag that down. That's all I know. I'm just gonna support that because that's gonna stop at some point here. And sure as shit, we get him loaded in the ambulance, and we're not 2 minutes out of the door, and homie decides
He's too tired.
I'm not gonna breathe anymore.
I'm tired. Now time.
That was also the first time I was ever introduced to the IO drill.
Ah.
Yes.
Was it my father-in-law?
No, it was not. It was
Sounds like a very father-in-law type call.
No, but it was. If you know your father-in-law's closest ginger relative,
Oh,
it was him.
all right,
And,
all right.
I'm wondering who's doing construction in the back of the ambulance because all I hear is, and I didn't know this was a thing. So yeah, I'm never too fond of urgent care dispatches. They give maybe the basics, but you're right. They give their interpretation of what's going on.
And I'm going to tell you too, like, not to interrupt you.
No.
I worked at an urgent care, but I didn't do anything medical. I was the check-in girl. And guess who calls the ambulance? Me.
Yep.
And I have no idea what's going on. So they're having somebody who hasn't evaluated the patient, has no medical knowledge, and this was pre all of my healthcare experience. And I'm calling the ambulance and I'm like, well, what for? And I'm like, yeah, I don't know, chest pain. You make something up. What do they check in for? You get, that's all the information you get. So it's not reliable information.
Yeah. And even more so, it hurts when we'll get called there. There is an urgent care in my first due ambulance district. And we will get the call for the person they haven't even seen yet.
Yeah.
Because they refuse to see them. Right. You couldn't meet your copay. You don't have insurance.
Right.
We're not even going to touch you. So we'll call 911 for you. And I've taken more than very critical patients out of the urgent care that could have received some kind of stabilizing, some kind of treatment, but were given nothing for lack of $20.
Right.
So yeah.
Or even the urgent care that's in our district, we see it that they walk in and they go, "Oh, you're too sick for here."
Yeah.
Yeah, we're just gonna call now. Sit in the waiting room, and we'll just
Yeah,
call
we're
you
not
a
even going
bus.
to pull you back.
Right,
We're just
we're
going
not
to call
even
the
gonna call, like-
ambulance. Yep.
It's incredibly ridiculous. I mean, there's a lot of things urgent cares do, and they do very well. And then there's others where it's like, why do you exist?
I got a fantastic set of stitches from the urgent care one day. I mean, it actually worked really, really well.
I went there when I broke my ankle. They splinted me fantastic. Like they're definitely useful for certain things,
Yes.
but
So
I don't want to sidetrack the call review, but it says something that so many people are using the urgent care as primary.
yeah.
That's all they have.
Right.
Which I think is a great argument for community paramedicine, outreach from the local hospitals, say maybe we can take some of these really acute cases or the inappropriate cases, even, the little sniffles or the whatever it is, say, okay, let's move that to community paramedicine rather than clogging up this very viable, useful pathway to the ER.
And there's a snowball effect on it because when the urgent care is overwhelmed, not too long, you're going to get the ERs that overwhelmed, and then you're going to get the hospital itself that's overwhelmed. So you could stop that influx.
Yep. All right. So let's continue. You're dispatched again, priority 1, Delta priority to the local urgent care for a 71-year-old male with difficulty breathing. You got that one transporting ambulance with an EMT basic and a paramedic. Okay. EMS arrives. They enter the facility. They're met with a nurse practitioner, not a doctor, or typically you see a PA, but this is a nurse practitioner in this one, and an RN inside the patient room. The nurse practitioner reports a 71-year-old male with COPD exacerbation. They report a history of COPD and a hypertension history. At this point in time, no vitals are taken. The patient is seated on their exam table in an upright position on their portable BiPAP unit. Not this is the patient's portable BiPAP. Not the urgent cares. Not the urgent cares.
Patient got BiPAP with him.
Hasn't worked in 6 years.
But don't worry, I got the BiPAP.
We got a BiPAP.
And on that portable BiPAP, their SpO2 is 77%. So for you guys as a table, what do you want to know now? Like, is there information that you want to know right off the bat that this report didn't provide to you guys? Maybe
That's where I look at Gerard. Sorry,
I'm waiting.
This is going to be an adjustment.
Did he come in on the BiPAP?
He did.
He did. Have they done any sort of intervention
No.
at this point? No?
Nope.
Nothing.
Nothing.
Okay.
Does he know
this was again one of those. Oh, you look really bad. Let's just call a truck.
Does he know what his normal O2 sats at?
So typically, no, he does not. Sit there and go, "Oh, hey, it's 87 today. I'm doing good."
Some people do know
Some
that.
people do.
Did you? What is his mentation?
We'll get there.
Okay. Be that way. I mean, is he a happy hypoxic? Is he?
No.
Okay.
We will get to how happy this poor guy is.
He's the
grumpy
Dwarf. Okay. All right.
So with this report, before we get into what this patient actually looks like, is there a treatment or a route that you guys are starting to think of initially? He's on BiPAP, his portable BiPAP. COPD exacerbation is what you're told, with a SAT of 77. No other vitals are taken.
What is generally better for patients, BiPAP or CPAP?
BiPAP.
Yeah, typically BiPAP. And we'll get into why later on in the call. That was a teaching point that I'm going to talk about.
But just from a BLS perspective, I'm looking at if he's already on some kind of, we'll call it airway splinting. Right? If he's already on some kind of device, I'm going to consider buterol. I don't have the ability to do a duoneb as a BLS provider, but if this is an ALS truck, maybe we're looking at adding the Atrovent to the albuterol, something to open up the airways a little bit more since we're already splinting them with the BiPAP.
Mm-hmm. All right. So let's see what this guy actually looks like. So the EMS crew approaches the patient. They find him alert and able to follow commands. However, he only answers in one-word statements or with silent head movements. So the nod yes, the nod no. Okay? He appears in obvious respiratory distress. He appears tachypnic, extremely diaphoretic, with significant accessory chest muscle use. And as this paramedic described it to Gerard, who then described it to me, he had the respiratory bug eyes, which if you've ever seen those, you know exactly what I'm talking about. Okay, I there's no way for me to explain what a respiratory bug eye is. It's almost like GI smell, like you walk in and it just is like you can't describe it. However, they find the airway is open, it's clear. He is wearing that personal BiPAP, and peripheral pulses are thready and weak. Presentation, bad, good, ugly. What are your thoughts?
Pretty ugly.
Pretty ugly. I agree. Pretty ugly. Okay. Does this change any of your guys' immediate thinking to what this gentleman needs right here? Is there assessments that we need to be doing? Is there treatments that we need to do? Is this COPD?
Did they listen to lung sounds?
See, I almost kind of want to start over, like start fresh. Like, so urgent care has already put in our heads that it's COPD.
Yes.
But what if it's not? So why don't we go back to square one, start, and move quick because he's not doing well.
Okay. Is the BiPAP okay here?
So is the BiPAP working? Because it doesn't really seem to be for me.
To me,
at 70?
To me, he's 77.
Yeah.
That's not
working in my book. Yeah, no, I would take it off, start at square one. If I have CPAP capabilities, maybe consider that, see if that improves him at all.
Okay.
On my machine.
All right. So here's what the crew does, right? The medic pulls the nurse practitioner aside to gather a further medical history because they need it, right? COPD and hypertension is the only thing they've given so far. The EMT begins to get the stretcher ready to extricate the patient. Their thought process in this crew was get them out of the urgent care to our office, right? We can treat them better by ourselves. The RN staff is now out of the room gathering paperwork. The nurse practitioner, when questioned, denies any CHF history, no significant cardiac issues, and they were pneumonia positive. They were treated for pneumonia 4 months prior, and the NP stated that this gentleman is COVID-19 negative. Again, who knows when that test was...
pandemic.
Right. Who knows when that was taken, but this was during the pandemic, so that's a question that we all should be asking, right? The medic goes, okay, goes back into the room, right? The medic finally listens to lung sounds. Here's wheezing on inspiration and exhalation bilaterally in the apexes. Here's nothing to severely diminished in both bases. Great. Okay. Why is that great?
It's not great. It's the sarcasm.
But what do we gain from just that?
Not using a lot of or he or she, I don't even remember, is not using a lot of lung tissue to perfuse right now.
Okay. So we're thinking perfusion issue at this point, possibly, right? Definitely not having a lot of gas exchange
Especially
to facilitate that perfusion. You said?
Especially in the lower, he's got nothing going on.
Yeah, I mean, if you're severely diminished or absent,
and then
there's no
your
air
oxygen
getting down
saturation's
there.
at 70% already. So
Yeah, 77 at this point. So the medic decides this is about the time I should probably get a full set of vitals since the nurse practitioner and the nurse didn't do that yet. So peripheral pulses via actual palpation is unobtainable. The medic feels a pulse, a radial pulse, but cannot count the rate. BP on the auto cuff or the random number generator on your monitor spits out 200 over 150. They recheck this with a manual cuff, and it's 210 on 160 via the manual cuff. And the respiratory count is around 36 to 38, significantly labored on this BiPAP. Treatments for you guys. Where are you going here? I know what I'm thinking as the paramagician at the table. And I'm thinking exactly what this provider was thinking right off the top of my head.
You've just got a COPD history, right?
That's what the COPD and hypertension.
Not an asthma history or anything like that.
Not that you know of.
Because
How old is he?
71. As of right now,
Why couldn't they get
can
it?
feel
because it's weak and thready.
It's weak and thready. You can't count it. You can feel it. And they didn't. The pulse ox hasn't been put on from the EMS crew nor the cardiac monitor at this point in time. So let me jump in here. I, as a provider, are already thinking this guy is an intubation candidate off the rip.
I was going to say, I mean, are you
Right?
going to even
I'm
waste the time and
calling-
try CPAP, or are you just going to intubate them at this point? You know?
At this point, CPAP until I get a second medic, and then they're getting intubated.
I would nebulizing the CPAP until you're ready.
Yeah. I think CPAP, a duoneb, as long as you have the CPAP.
And I also wonder how long he's going to handle it.
Yep.
I mean, if he's at 70% and then he loses his mental status, there goes your CPAP. So I feel like I would jump on that while I can and see if that can do anything.
I agree. I think this is one of those calls where I'm calling for the second medic at this point in time. Unless you're, one of those weird agencies sections that can do one provider RSI, and then by all means roll the dice, but I'm not with that. So this provider does actually think the same way. RSI is 100% warranted in this for the reasons that you're stating. I agree 100%. They call the second medic to the scene. So at that point, the crew decides, outside now, right? They move the patient to the stretcher. Now, this is the first time where in the story it is expressed the size of this patient, right? 71 years old, about 6 feet tall. However, like 375 to 390 pounds. Bigger gentleman, right? Bigger gentleman, probably not the best tube, I would think, like going through the heaven criteria.
Right.
I'm thinking this is probably a bad intubation. That's just, I don't know. It's just my personal thoughts. Once the patient's on the stretcher, they attach the pulse ox probe to their cardiac monitor. It still reads 77%. They still have them on the BiPAP. Okay. It is their decision to take the gentleman off of the BiPAP at this point in time and put him on a non-rebreather at 15 liters. Right now, they don't have CPAP at their disposal. It's in the truck. So this is you used a great word, a splint, until you can get them to the CPAP, right? And then they move to the ambulance. I'm going to pause here. Where are your guys' heads at with the treatments that this crew's doing? Do you want to do something different? Would you have done something differently inside before moving this gentleman out? Where do you think this is still COPD the way he's presenting with the lung sounds and stuff that's presenting? Do we need more history? What do we need? What are our thoughts?
This is where I look at Gerard.
Do we know where the history is obtained from, like past medical records or directly from the patients?
So they are going off of past medical from the facility. He, again, was not able to answer in a lot of verbiage, so they just said, don't talk. We'll just get it off the computer.
Focus
So
on
they could be
breathing.
missing something huge.
Sure.
You have allergies? Any?
No allergies.
Nothing stands out.
Nothing that they were told.
Okay.
This crew has not looked at paperwork.
Edema.
No edema at this point in time that you can note.
I mean, he's
I guess he's
400
that big,
pounds,
you
so-
can't tell.
And
Fine.
that's a very
Yeah.
accurate. Sometimes when you're looking for edema, it's just all fat. Like you can't tell. Cankles is a real thing. Are we good with the route that these guys are taking?
I
Do we
think
still
given the
think-
information they have, yeah.
Yeah.
Okay.
I mean, I don't think, I think they're right on.
Right on. All right. So now they're in the truck. They're in the ambulance. The medic decides switch them from the non-rebreather to the CPAP in belief that this is still a COPD exacerbation, right? There's wheezing. They're clamped up. There's, no, air movement in the bases. Maybe this CPAP can get stuff down into the lower lungs, right?
Okay, question.
Yes.
So,
I'd be so disappointed if she didn't say that every single podcast.
That's
I
very
always
accurate.
have one. So, COPD gets so bad that you're wheezing in the apices, you're so closed off in the bases.
Mhm.
CHF, can't you get the same way? You're so fluid filled that there's nothing that you're hearing in the bases. And
Would you be wheezing?
Yeah, actually, you can get
You
wheezing.
can. But what else would you hear?
Ronchi.
You could. I'm not saying that this happens every time. So in my mind, like they're going with the COPD route, which I'm all for because given what they have, I think that's the best option. But I'm not throwing out my CHF yet.
Okay. See,
Because you would also hear fluid, but you might not always.
Right, especially if they're that clamped off all the way up to their APCs already.
right. And remember, you and I have had the conversation, and I think it's a great conversation to throw in right here is the fact of why you get silent lung sounds in a CHF patient, right? The lungs are trying to protect the alveoli that still work, right? They're clamping off all of those bronchi that have fluid in the alveoli. So that's where you get that cardiac asthma from, right? It's just wheezing, but it's not actually asthma. It's in response to the CHF cardiac problem. So when you have left side heart failure, you could get rails to begin with in the lower bases, and then all of a sudden you hear nothing but silence and wheezing in the tops. And that you don't hear the rails
happens,
anymore
right.
because everything's clamped off.
And if somebody his size, you have a hard press to find the other markers for CHF.
Right. It's very true.
And I don't disagree with these guys for going down COPD first but I would not throw out the CHF, and I'm keeping nitro in the back of my mind.
Yeah. I agree with everything. I am looking at the CHF solely based on blood pressure.
Yeah.
At this
Yeah.
too. Like you don't
The
typically get a
hypertensive like that.
COPD patient with 210, 200
Right.
over 150s. That to me is a CHF.
Yeah.
Can they get a head nod, yes or no, if he's been taking his hypertension meds?
He has.
that
He
would
is
also
compliant
affect
with all of his
that.
meds.
Okay.
Yep. Typically
But even
compliant.
if he wasn't, you're still concerned with CHF at that point.
Well, yeah, but it would factor in a whole lot more than if he.
Right.
And just think, look at. I mean, he's unhealthy to begin with,
Right.
right? He's overweight. Overweight people tend to have really terrible hearts. Not the best lifestyle, right? So it's definitely a possibility for CHF,
Right.
even though they're like, "Hey, it's COPD. Go down COPD."
Because that little seed was planted in their brain.
Well, that's
If-
that's why I have an issue with urgent cares. They plant the seed and then we never look around for anything else.
Right. And I would be really scared because if I'm a paramedic going in thinking solely COPD,
Right.
I'm going to give them CPAP, give them the oxygenation. But if
You're not
they're
fixing the
if
problem.
they're clamped down so hard, I'm now thinking epi. If they're this bad, their
Right,
respiratory
right.
rate is gold for epi. Their presentation looks gold for epi.
Absolutely.
Epi fits in COPD exacerbation. Well, now if I give them epi and I open everything up, I
Trouble.
might have
You're in
just
trouble.
I might have just screwed them if I don't have them on the CPAP.
Which is why for me, for these guys, if you're going to go with the COPD route, that's fine. But when you're thinking meds, like my first choice in the back of my mind that I'm keeping is nitro. I'm not even considering epi.
See, I've been sitting here thinking epi the whole line. If it's not CHF,
Right.
If this is truly a COPD exacerbation, then epi is going to be.
The go-to.
Again, I put the caveat of BLS provider. I can give epi now for asthma attacks, but if my medic isn't thinking epi, I'm going to be like Tinkerbell on their shoulder going epi, epi, motherfucker. That's what I'm going to be whispering to them. But if it is CHF, it goes back to I want to make sure I've got that splinted positive pressure airway before I do this, so that we don't release all that fluid into all the lung spaces now.
Mm-hmm.
But I've been thinking epi for.
All right, well, let's continue, see what these guys do. So they're in the ambulance, remember? The medic switches them from the non-rebreather to the CPAP, right? They're going down the COPD route. While placing the COPD mask, the patient begins to horrifically cough, right? And this is not like the I'm about to die cough. This is just they horrifically cough.
The COVID cough?
Not the COVID cough. They
COVID
tested
negative, remember?
Right.
It was 3 months
that
ago, but
means
it's fine.
anything.
It was COVID
Right,
negative.
because that means anything.
Because nothing changed in 3 months. Not at all.
So the medic continues after the cough. They continue to place the CPAP. They place the PEEP at 5. Okay. Yay PEEP. We'll have a discussion about PEEP. So
Seen the rabbit video?
Rabbit
You
video?
have to have seen the rabbit lung video.
I haven't even seen a
You
rabbit
haven't
lung
seen the
video.
rabbit lung video?
No.
All right. Never mind. We'll put it in the show notes. I promise. I'll find it for you.
Awesome. Send it to me.
The link will be down below, folks.
Is it down below? I didn't know that.
There,
Okay, cool.
It's the show notes down below.
Makes sense.
Yeah. All right. So the medic, while putting on all the CPAP stuff, the medic asks if this cough has been productive at all. And the patient responds with a head nod, yes. Okay. And the medic then asks if the productive cough is normal for this patient. And he nods yes. Okay, cool. So the medic then asks, what the heck color is it? Well, the patient can't talk. So the medic quickly realizes,
catch
well,
it.
now I'm going to have to go down to rainbow. So he goes, brown, head nod no. Green, head nod no. Right? Yeah.
Point to where it is, sir.
That would be some Broslo tape.
Yeah.
Which color,
Which color is it?
That'd be so much easier. But eventually, they get to red, pink.
Oh.
And he nods yes, finally. So The EMT during this time is attaching the cardiac monitor. That's important. So,
Go EMT.
before I jump to what you guys are thinking, I want to first quickly butt in and talk about PEEP. You said yay PEEP. I love PEEP, right? For those who don't know what PEEP is, it's positive end expiratory pressure. It's the pressure that remains in your lungs on the end of your exhalation phase. So what keeps your lungs open? That's the pressure that we're thinking of, right? All of that nitrogen air, all of that, stuff that remains, that dead air that they talk about in class, that is what remains in your lungs. Typically, we have a PEEP of 5, roughly 5. It's a little less than 5, but roughly 5, we'll say, at all times. When we are trying to oxygenate a patient, we can do it 2 ways. We can give them more oxygen, so increase their FiO2, say from 60 to 100. They're already at 100% oxygen. So the only way to oxygenate your patient is to give them PEEP. Increasing PEEP is going to increase the pressure within the lungs to keep the lung tissues open, specifically the alveoli for gas exchange.
So ultimately what that does is you hear about like recruitment. So what that's doing is when you're thinking of your alveoli and you're thinking of the little bundles of grapes, that's how it was taught to me.
Yep.
And you think of they're shriveled up like raisins. When you increase the PEEP, you're recruiting, so you're rehydrating those raisins.
Yes.
And the more raisins you get to rehydrate to grapes, the more oxygenation you get.
Yes. And
that's why we increase PEEP.
And that's why
That was
we
the
increase
best
PEEP.
analogy ever.
Thank you.
yeah.
I dressed up as a grape to do that in class.
But without the recruitment, what ends up happening is those alveoli actually start to collapse and they stick together. And the air is not able to get down into all the fields without that pressure reopening the field. So, like I said, the rabbit lung video, which will be in the show notes, actually shows this perfectly. You can see in the lung tissue how the sacs, how all the lung fields open up upon the ventilation of the lung. And then upon exhalation, you see the entire lung tissue just collapse. And it doesn't just deflate like a balloon. It almost shrivels up. And without PEEP, you lose the recruitment that Emily was talking about. And you get a much harder time re-recruiting those alveoli for the next respiratory cycle.
And here's the biggest thing. I did a video on this. Did everyone see my clamp video? Right? It's the biggest. Oh my God. The biggest. You're gonna hear about it now, because the people that didn't watch the YouTube video on why everyone should carry clamps, EMT or medic, doesn't matter, is for recruitment of PEEP. Right? If you have an intubated patient and you go and you've been, bagging them with the PEEP valve on, or you've been CPAPing or not CPAP on a BVM, but venting them with a ventilator with PEEP. Thanks. He's making never mind.
I was making fun of Mike. She was telling me that it's on the Facebook page. I said, I saw it on the Facebook page. I just scrolled past.
Just didn't watch it.
I just kept going to look to the next meme.
Which is okay.
Put it in a meme.
Which is
people
okay.
are paying attention
If
to.
you
Apparently.
condense all your videos down to meme form.
I can't. I need Gerard to do that for me.
All right.
Paging Gerard to make a meme.
It'd be done like that.
Exactly.
So yeah, with the idea of recruitment and PEEP, if you've had an intubated patient, they're on a BVM with PEEP, they're on a vent with PEEP. If you've been, breathing and ventilating for these people with PEEP for, say, a half an hour transport, now you're there at the ER, you're about to do your bed switch. Okay, cool. You have to change that vent tubing, or you have to switch the BVM from one thing to the other. As soon as you pop that BVM or vent tubing off, what happens? The chest compresses, pushes out all the recruitment that you've just gained for the last 30 minutes.
You take your finger off the top of the straw.
You don't put your nasty ass finger.
Well, no, what I'm saying, so we've all gone to McDonald's and gotten the shake. and you
does that?
You get them. What? Go to McDonald's and get a shake or what?
Shamrock Shake should be coming out soon, and I am thrilled.
So, but it's like when
I'm
you've got
losing
fluid
control.
in a straw, you put your finger over the top of it, and you can pull the straw out, and the fluid stays in the straw. You're
Correct.
creating a suction within the tube.
Hence why you clamp the tube.
So that's the finger on the straw.
Exactly.
Just use a clamp. That'd be really gross.
Then they're gonna get pneumonia on top of everything.
Damn vent.
I mean, if you're putting your finger on the tube, just lick it.
It's a gloved hand. It's a gloved finger.
It's the glove that I haven't changed since I got in the ambulance, and I've touched everything.
I just want to say this is why,
Including
side
the
note,
tablet several times.
Exactly.
this is why we don't record at night. We lose all control.
Is it past Emily's bedtime yet?
It's past
Past my
mine.
bedtime.
It's not
After
past your
5
bedtime.
p.m.
Your bedtime's 3 a.m.
Yeah, we still got time until my bedtime. Anyhow, so that was my PEEP discussion. So I think PEEP here is awesome.
I was
right?
gonna say I actually would probably go up. Like I mean, like
from
how did
5?
his oxygenation do from on the non-rebreather or on the CPAP? Did it improve?
It
at
did
all?
not change. No.
Yeah, I would increase that.
Okay.
What were his on the BiPAP? What were his settings?
I don't have settings, but I have SpO2, which was 77.
Yeah, I'm just
But I don't have
wondering
settings.
if the gates needed to be moved up for this particular instance. You know, if the high and low PEEP thresholds needed to be changed
Right.
on the BiPAP to accommodate whatever this is.
But then
Right.
the CPAP would have worked.
But
because
then-
the CPAP ultimately is moving those settings up.
if you've got the PEEP at that right, if you gauge the PEEP correctly at that point, so we've got him at 5, maybe he needs something more than that.
Right.
I would. Moving on.
I'm only going to move on a little. And just for those that don't understand CPAP, BiPAP, right? CPAP is continuous, BiPAP is bi-level. So they do the same thing. CPAP just pushes one continuous pressure at your face. So those that, especially like asthmatics who typically have trouble getting air out, are now breathing against this continuous pressure, which is why BiPAP works really well for them, because you have 2 different settings. You have an inhalation pressure, you have an exhalation pressure. So I think it's a very interesting idea, changing settings, except that most EMS personnel, unless you're on a flight team that has BiPAP in like their LTV, don't know what the heck they're doing. It's CPAP or nothing. CPAP or BVM at that point.
This will go to a future conversation of education standards.
Yes. Kelsey has a question.
So would it be better for, like, let's say this provider does know how to work this patient's BiPAP machine. For somebody like him, would it be better to have a increased pressure in all fields when he's inhaling and exhaling, or just inhalation, just exhalation?
I'll let Emily take that.
I would increase both settings, but I would probably increase the inhalation more. The other thing that I would actually consider doing is flipping. So you normally have a 2-to-1 inspiration to expiratory rate, right? So it's 2 seconds in, 1 second out. So consider flipping that.
Give them a longer
time.
time.
Right, exactly. Give them a bigger chance to get everything out.
Yeah.
But
especially
when you're
COPDers
talking
are
about-
air trappers.
Yeah. So for when if you're thinking COPD,
Not that they're noticing.
when you're talking about PEEP, though, I would want to recruit more lungs, so I want that pressure to be higher. I want to recruit as much lung tissue as I can without blowing up their chest. You can't just blast the PEEP up as high as it goes and call it a day.
I mean, some people would, but
That's what we call
Please don't.
neurotrauma.
Please don't. Yeah, please
Even
don't.
worse thing.
so at this point in time, okay, we'll get back. He's said he's bringing up productive sputum, red in color. He's still 77% at this point in time. He's on the EMS CPAP with a PEEP of 5. Okay, blood pressure still was that 200 over 150, 210 over 160 on the manual cuff, labored at 36. Respiratory count, pulse, still haven't found that out yet. Okay. Are you guys, with this new information, are you still on the COPD train? Emily is
I've jumped.
ferociously shaking her head.
Listen, I was straddling it. I've totally
We
jumped
were on
to
the
CHF.
seesaw before.
Yeah.
Now we're just.
Okay,
Yeah.
so
I don't think that they did anything wrong following COPD up until this point, but I think with the hypertension and the pink frothy sputum, or however you want to describe it,
yep, ready
think-
pink
yeah.
sputum.
I think
So
I'm
you-
going CHF.
You're on the CHF train.
on the CHF.
I think everyone is.
Absolutely.
Yeah.
Everyone here is on the CHF train.
I'm punching that ticket now.
So the medic, who is fabulous, decides I'm on the CHF train too, right? Immediately goes down Emily's favorite path, administers 3 sprays, sublingual 0.4 milligram
I love this
nitro,
person.
1.2 milligrams total. 3 sprays right on the tongue, right off the rip. Get it done,
But
right?
you got a lot of blood pressure to play with here. So
Yeah,
you know,
Exactly.
even if we tank it, that's still going to bring it down to a normal rate.
Right.
Probably
And
still hypertensive.
right.
probably still hypertensive, right? So at this point in time, the cardiac monitor, remember the EMT was placing the cardiac monitor on while all that conversation was happening. And the initial rhythm on the monitor shows a SVT, a supraventricular tachycardia at 200.
40.
Okay. The medic goes, 12 lead, please. And 12 lead performed.
I just want.
Okay.
The EMT knows how to do a 12 lead.
Yes.
Fantastic.
Yes. I agree.
Because I think that's absolutely amazing.
As long as they're, to me, as long as they're taught right,
Every
yay
time.
me,
Yeah.
Sticker them up.
yay me.
It's just I'm jumping into that educator role of it's unfortunate that so many EMTs are taught the monitor is magic. It's a witchcraft item and you do not touch
You
it.
don't touch it. And in fact, when you go for it, I'm going to slap your hand away because it's not
You're
yours.
good
See,
enough to
no,
carry it.
whoa,
You
whoa,
can
whoa.
carry it from
Right,
know
'cause
the-
it's too heavy.
The fly car to the ambulance or the ambulance
To
to
the fly
to
car.
the scene or wherever it is. You may be allowed to hook up a blood pressure cuff and a pulse ox, but don't you dare touch those 4 liter
Which
the
is
12 liter
which is
runners.
crazy
Don't touch
because
the
I have
colors.
the opposite end of that spectrum where I'm looking for my monitor and it's already in the EMT's hand in the house. And
I
I'm
can't
like,
tell you how many times
what-
I've had my hand slapped
what?
away.
Like you don't need to be carrying that yet. Like I'll let you play with it, do whatever the heck you want, but let me touch it first. Like you got other
mine.
things to do, like a manual blood pressure.
So, again, that's get that. Don't trust the monitor only as far as you can throw it. Which, if it's a life pack, you're not
Not
throwing
very
it.
far.
But it was actually my wife who taught me how to do 12 leads because it was never covered in any of my classes, and even in the first few months of ride time, she was a coworker at the time and now wife, which very lucky.
Yeah, you. She's awesome.
She's absolutely phenomenal. But she was the one who taught me how to do 12 leads, and it's not covered. And so, yay for this EMT knowing, okay, 4 lead, simple enough, follow the damn directions,
And even then they fuck it up.
The leads are labeled.
Yeah, they're labeled.
Yeah,
You don't
but
even have
even
to
then they
remember the
fuck
old,
it
like,
up and they
smoke
put them
over
on the
fire.
stomach.
I know.
Like-
So, out on the limbs, please. That's why they're called limb leads. But then knowing how to hook up a 12 lead and acquire that so the medic can be focused on other things. I mean, I hate to say it, it's a monkey skill. One of those things that you should just know how to do. There's really no higher thinking in terms of, okay, here's where the leads all go.
Right.
But it's one of those things that just advances the professionalism of the team.
I agree.
Makes the patient care much better.
Yep. So the 12 lead spits out of the very heavy monitor, and
They're using life packs.
it confirms AFib rate again 200. No SV or ST elevations are seen upon the looking. The AFib is not actually seen. It looks like an SVT. It's just what the little old computer box is saying. Rapid AFib. Whether or not this paramedic believes that little printout, I typically tend not to, or at least go, okay, that's what it's thinking, but now let me find out what it really is. Maybe they match, maybe they don't. Okay. Is that something noteworthy for you guys, that we have a blood pressure 200 over 150, but then we also have a heart rate of 200? You're thinking.
I mean, yeah, it's noteworthy, but I'm not. What are you gonna do? Give fluids? No.
Okay.
You know what I mean? I don't think I'm really gonna touch that heart rate just yet.
Okay. All right. Interesting thought process. So let's carry down the stream
I
here.
was wrong.
Huh?
That means I was wrong.
Or you just would have done it differently. It doesn't mean
Or
you're wrong.
I would have done it differently.
Okay. So after the 12 lead, medic decides I got CPAP. I'm going down the CHF route. I've given my sprays of nitro. I'm going to try and fix that wheezing, right? Mixes a duoneb. That's albuterol, Atrovent, the 2.5 milligrams in 3 mLs of fluid for the albuterol, and the 0.5 in the 2.5 milliliters of Atrovent, okay? The EMT at this point finally begins to sift through the paperwork packet, right? And a history of AFib and CHF are both discovered within the paperwork. That was not earlier
Love
reported,
it.
right? Shocker.
Way to
right?
bury the lead.
Glad I figured that out already.
Right, we figured that out,
Yeah.
right? It's nice. It's nice to confirm.
I
what we're
agree.
thinking.
I
we
think it
started
was-
taking interventions that maybe would have sent us in the wrong direction. So we're behind the 8 ball, but we're not buried.
And I think I would absolutely still encourage the EMTs, like, go through the paperwork, make sure we're not missing anything. But that's why I say don't take everything that any doctor's office, it's not urgent care. Don't take it all for, keep it in the back of your mind, but
Right.
keep an open mind.
Absolutely. And I think this was good to sit there and go, hey, I should probably be looking for other stuff. What meds are they on? Do they have any allergies? None of that was really told by the facility, right? COPD, hypertension. Here's your patient. They have trouble breathing, right? That's what we started with. So at this point, the medic on scene is thinking, where the hell is that second medic that I called for so much earlier for that RSI? Well, the dispatch returns the message saying, poorly, sorry, that second crew is stuck at a train crossing. They're going to be delayed for like 15 minutes. Long train.
Are they in the direction of the hospital, or are they in the not direction of the hospital?
These guys are actually in the direction of the hospital.
So
The second paramedic was coming to them, right? Behind them.
We're going to start moving in that direction, because the other thing this patient needs is maybe some diesel therapy to get them to definitive care.
Okay. I can agree with that. Sadly, these guys don't wait. They start going. So that's a good thing. They did not wait for the train. They didn't wait the 15 minutes. We've talked about how people wait, right, on this podcast. But these guys, through the paperwork, actually found a DNR DNI on a MOLST. So the RSI would have been thrown out the tube anyway, right? You're shot at that point. So why do we need a second medic, right? Here's where definitive care is okay in my book. And now, right? Before we go on, I want to backtrack into just, we've had an earlier discussion of the CPAP and CHF with the duoneb, right? We want the CPAP, we want that positive pressure, even if it's BiPAP, BVM, whatever type positive pressure you have, pushing that fluid through the alveoli into the vascular space. We want that. However, I think it's great that this paramedic waited to do the duoneb until the CPAP was up and running. Because what I see so often is you hear wheezing and you give the duoneb and then you flash them. We've already said that. So point taken, one thing to save your patient's life and to make it so that you guys aren't behind the 8 ball. CHF, positive pressure ventilations, then
open them up.
Then open them up. If you are not giving them positive pressure ventilations, do not give them the shit to fix the wheezing. Don't give them the albuterol. Don't give them the Atrovent. It's not worth it.
You have to remember for a CHF that's wheezing, it is their body protecting itself.
Right.
So don't take it's like the conversation we have for the tachypnea on an acidotic patient.
Yeah.
Their body's trying to fix it. Don't change that.
Yeah.
Let
agree.
the body
Fix the
fix
pH
it.
balance before you
Right.
Before you attempt to
Don't
shut
bag
down
them
the compensatory
down.
mechanism.
Exactly. When their body's doing a great job compensating right now.
Right. If
So
they're in
it's-
DKA and they're breathing at 48,
leave
let
them at
breathe
48. Right. Don't change that. And it's the same thing with the CHF. Don't open it up when their body has clamped down to protect that airway.
Right.
Let it go.
Unless you have the positive
And-
pressure.
right.
Then, by all means, have at it.
Right.
Fix it. Awesome. There's a place for that fluid to go.
Absolutely.
Otherwise, you've just now killed all the...
Drown them.
Wouldn't
Right.
that make the CPAP work better, theoretically, by opening everything up, make everything push out?
Theoretically.
If you're quick enough. If you're applying the duoneb and the positive pressure in close enough succession to one another. He's talking about, flashing the patient. You open everything up before you establish that pressure pushing things back.
Mm-hmm.
It's going to be a fun few minutes while now you're fighting against that fluid pressure coming out of the vasculature.
And remember that albuterol has to be able to get to the lung tissue to be able to work. So if you're slamming them with CPAP and then automatically starting the neb, it's probably not going to do as much as if you gave them 5 to 7 minutes on CPAP, then gave them the neb, which is kind of what they did here. They waited for a few minutes to let the CPAP function and give you that starting point, and then they gave them the duoneb, which I agree with everything here. Like, there's nothing that I've seen so far that I'm like, bad paramedic.
Yeah, no, they're doing a great job.
They're doing a great
They're doing
job.
a great job.
They get the
Right?
gold star so far.
Yeah,
And-
seriously.
On this show,
That's pretty hard to
that's
get.
pretty damn.
You're not doing the bad paramedic, no hot meal for you.
You're like, seriously, these guys.
Depending how this
Are
goes, you
doing
might
great.
get ice cream after.
Hey, they're not firefighters.
They get ice cream with sprinkles.
I didn't say they were winners. They are still a paramedic.
These guys may or may not turn into winners. We'll see.
true, yes.
Okay,
I know they're doing well.
They're
They
doing
really
very
are.
well.
We're on the way. We're between second and third base right now.
Yes.
We're not on the home stretch yet, but
There's nothing I would have done differently yet.
except for
Increase the PEEP.
no. What was the other thing? Oh, the heart rate. You're
Oh,
right now
yeah.
sitting on
Yeah,
don't fix
I'm
the heart
not,
rate.
yeah.
Okay, so after this paramedic realizes they're not getting their second medic, this patient has a DNR DNI. They quickly are realizing that they're being smited by the EMS gods. That was literally what was told to me that they felt at that moment in time.
Smite me, almighty smiter.
Not really the like pucker factor, like, oh shit, this just got festive, but like, why me? Right? Anybody but me. So they quickly pull out their protocol booklet, right? Best decision I think ever, right? I do it all the time. I think more people, when they're unsure, should go to their resources.
Why are we afraid?
And that's it. Why?
We're given
Because we're
this
too
tool.
proud.
Yes.
And it's unfortunate because we're given. Yes, there's a cookbook mentality behind it, but at the same time, it's going to remind you
Exactly.
of the other pathways that maybe you haven't considered, and maybe we can.
Or maybe
we
you
can tiptoe a little bit down this pathway
Right.
and see what's going on.
maybe you considered it and it didn't fit then, but it does now. It's
Yeah.
going to bring you back to that.
But let's not be so proud
Yeah.
that we have to think, oh, I took the protocol test. I know everything backwards and forwards. Well,
Right.
okay. In a calm testing environment, yeah, you did. In a nice, air conditioned,
Yeah.
well lit.
Already had breakfast,
where
had my
you
coffee.
crammed the night before. You got a good night's sleep. You got a good meal. You did your whole, what is it? Your
Scar.
thing.
yeah.
Right. All that. Right.
Go,
you got
Kelsey.
pissed off, and you saw something red, and you took your test. Right. But now, you didn't hang your head out and look at the red lights on your way to the call, so you're not nearly pissed off enough. I don't know. Use the tool that's been given to you, and refer back to those reference materials.
And I'm even okay with, even if they didn't want to pull out the protocol booklet, I'm even okay with them calling a doc and being like, hey, doc,
Phone a friend?
this is what I got.
Yeah.
Right? Like, yeah, phone a friend. This is what I got. This is kind of where I'm thinking. What do you think is the best route here? Lay out your options.
Right.
Be like, this is option A through option C. Which do you want? Or do you want to give me option D? Right? I think that's even okay. So this paramedic pulls out their protocol booklet, and they specifically told Gerard that they cross-referenced the C.O.P.D, the pulmonary edema, and the narrow complex tachycardia protocols. And they were specifically looking for a happy medium of all three, right? You're looking at me like, why?
Well, no, I'm just thinking of our protocols.
Okay. You're still looking at me like, why? I feel
Well,
like...
no, if they're thinking of the happy medium in their protocols, they've really done a lot of the COPD, the CHF. So now they're going to, I feel like you're going to tell me they're going to gear towards the heart rate. But in reality, like that might have been what I would have done being there.
Okay.
Because they've treated the other two.
They have
Retract
treated
your
the other
further
two.
statement.
What's that?
Retract your further
No, I
statement.
wouldn't have touched the heart rate when I found it. I wouldn't have done that.
How about now?
Maybe. I honestly would have to look at my protocols.
Okay. So...
I don't memorize them.
And it's not like an EMT in your spot is
Get
going to
blue.
do anything
Yeah.
for narrow complex
In
tachycardia.
fact, I'm not going to do jack shit.
Right. Like, I might. I
You
should.
I will radio the hospital and let them know.
Oh, man, sorry,
That's about as far as
guys.
my
Your
my
medic's
scope
still behind the
goes.
train, so
I'm
Right.
still in bed.
The box of things I'm allowed to do is only so big. So, yeah.
Mine has 2 levels on it. It opens up and stuff folds out.
It's like a
remember,
tackle box.
Remember those old tackle box? I was
Dude,
old
I still
enough
have
to.
that tackle box.
I was old enough to rummage in that.
Yes.
Yeah, in Poughkeepsie. It was fun. Okay, so the EMT is told by the medic to search the medication list, specifically looking for beta blockers or calcium channel blockers.
Yep.
Okay?
I'm so confused. Are they driving to the hospital at this point, or like?
No. I hope I'm going to go with no. I'm going to have faith that the EMT is not going through the paperwork and driving at the same time.
I would
You
hope.
know what?
I would hope so.
I'm going to go with,
be the first time.
but I like these two so far. I'm going to
Okay.
give them the benefit of the doubt.
They are not going to the hospital yet. However, this whole thing has, in the ambulance, has only been approximately 10 minutes.
Okay.
So it sounds like they've been there for like 45, but it's really only been about 10 minutes, right? It's not that terrible. So the medic is trying to gain IV access at this point, tells the EMT, go through paperwork specifically looking for beta blockers, calcium channel blockers. And they're doing that because this paramedics' narrow complex tachycardia protocols are based off of cardizem and metoprolol, right? Cardizem is a calcium channel blocker.
I was just gonna ask
Metoprolol is the
Kelsey
beta
that.
blocker.
You
Damn it!
just went over that last week.
I'm sorry.
It's all right. Kelsey knew that.
Okay.
Emily and I made the eye contact that I knew what you were talking about too.
Okay, so Kelsey, because
Great.
you and I have talked about this, what are the 2 paramedic drugs that are sodium and potassium channel blockers? Because we've talked about that too.
Amiodarone,
Is
sodium,
no
no potassium. Then I don't know what the other one is.
lidocaine.
Lidocaine.
We still carry lidocaine, right? Lidocaine was what we used for supraventricular tachycardias
Before all the fun ones came out.
Cardizem
Yep.
and metoprolol came out. And then they were like, oh, well, we came out with cardizem, so now we're going to use lidocaine for ventricular tachycardias. And then now amiodarone came out. And now lidocaine is like, you carry it, you push it for an IO, and that's it. Like, it's sad because lidocaine worked great.
It did.
It worked great.
But then something came along that was better. So
It's not better. They could charge more for it.
Oh.
You could make lidocaine for 3 cents a vial. You could make amiodarone for 3 cents a vial, but they charge $30 a vial.
Got
It's
it.
more or less all it was. Talk to Mark about that. He'll tell you the whole story. So the medic gets IV access, 18 gauge left AC, and the EMT finds that the patient is prescribed metoprolol daily. Okay. I don't have a milligram rate or, dosage, but metoprolol daily. So the medic decides, I'm going to fix the heart rate. Okay. I'm going to go down the narrow complex tachycardia protocol because it's still beating at 200. And what they're believing is an SVT, which the 12 lead monitor has said is an AFib, right? A rapid AFib. So this paramedic, per their protocol, starts an infusion of 5 milligrams of metoprolol in a 100 ml saline bag over 2 minutes. Are we okay with that? Everyone's like, yeah. I'm more or less looking to Emily. 'Cause
Yeah, I'm fine.
I'm gonna need an explanation of what's the difference between putting it in a bag and just push.
so, do you want to take that?
No.
Why not?
'Cause I don't put anything in a bag.
Really, it's
I push everything.
okay. So, for in the EMS realm, why we mix stuff is so that effects are spaced over a point in time, right? If we had medics, like perfect example is morphine, right? Why do we give Zofran before every morphine push?
Get all up.
Because we all suck. So protocol designers, the docs that sat there and said, this is what we can do, go, oh, look, they make people nauseous because slow IV push doesn't mean anything. They
Their
go,
definition of slow does not match our definition
Well, that's
of
it. There's
slow.
no,
Right.
what's the definition of slow?
right. So, a paramedic goes and puts it in
slow to
over.
me.
And it was
slow
over
to me.
10
It was over
seconds.
10 seconds, and now their patient's like, and you're like, okay. With metoprolol, if you're going to be slamming it in, which I assume most providers are going to go, oh, slow push, 10 seconds, right? Metoprolol as a beta blocker is going to specifically check your beta 1 receptors and how it typically we use metoprolol for blood pressure, but how we're going to change rate is that it actually elongates the time the electricity impulses take to get from the SA node to the AV node. So that time elongated is now going to decrease the amount of beats you can have over one period of time, which is why heart rate drops, which in turn is why blood pressure drops. So if we slam it, well, now we could have a big change over a short amount of time. We don't want to make people bradycardic. That's more or less, it's a safety issue.
Ultimately, you're diluting it to get
Yeah.
longer effects.
Right. I like it. So I agree with fixing the rate. And I want to talk all about chicken and the egg kind of thing at the end of this. So at this point, vitals are retaken. Blood pressure, 180 over 150 via the random number generator NIBP. Heart rate, still 200. Respiratory rate is 32. And the SpO2 is 80% on the CPAP with the Duoneb and the PEPA-5. The metoprolol's hung, and they beat feet priority 1 at this point to the large urban center, which is 35 to 40 minutes away. I'm okay with that decision. Even though it's respiratory, I'm okay with that. While en route, 10 milligrams of Decadron is given as a steroid, IV push. I'm okay with that. The second Duoneb is started. At 15 minutes post the first metoprolol dose, the heart rate had dropped to between 139 and 150 beats. Now you can clearly see an AFib, right? Still a rapid AFib, but an AFib. BP is 150 over 98 with a respiratory rate of 28 with now no accessory muscle use. Awesome. We see an improvement here, right? Wheezing is still present in the apexes, but now you have wheezing bilaterally in the bases.
We've gotten a few more fields involved.
Right. We're opening shit up, right? The medic decides to increase PEEP to 7.5.
Yeah.
Speaking of my heart.
Yeah, see, heart happy.
Heart
this
happy.
This is great. And a second dosing of 5 milligrams of metoprolol in another 100 bag is given over 2 minutes. Okay, this medic decides that just because metoprolol affects blood pressure, they're going to hang 1,000 bag to piggyback on that, but they only give about 100 mLs of it. So really, they're not overhydrating, overwatering this patient, right? They get to the hospital, and this patient is now able to speak in 2-word sentences, is more verbal, a little bit more perky, no eye bulge, yay, and a little bit less head nodding.
Do they look like Sid the Sloth?
The eye bulge?
Yeah.
I don't know who Sid the Sloth is. So I can't.
Iceland? Or Ice Age? Iceland, yeah.
The one with the lisp.
Yeah, almost. Yeah.
Like Sid when he's scared. That's what I'm thinking it would look like.
So at the hospital, vitals are taken again. BP 122/68. Awesome. Heart rate AFib at 95. SpO2 is 89. And they actually say, I'm feeling better.
Well,
right?
shit, why don't we just turn around and take him home?
Right, George. And at this
Sign
point, at this point in time, respiratory rate is somewhere in the mid 20s, 22, 24 ish. So, overall, I want to say this call went extremely well.
They get their
Compared
ice cream.
to
Well done.
everything that we've ever talked about, very, very well done. I think
I agree.
kudos.
But we did
Yeah,
end
good
up
job.
with like 9 providers in the back of the ambulance.
Damn
so
straight we
succeeded on that point.
They're still behind the train.
That's right. The RSI of doom, right? That's what it would have. Oh wait, he's got a mulch.
I
Never
need
mind.
another one.
So before I ask what you guys final thoughts are, I want to have like a chicken and the egg kind of discussion. So this paramedic gave 3 doses of nitro right off the rip for CHF, but then never returned back to it, decided to give the metoprolol to fix the heart rate. Do you guys, where do you think the problem started? Like, yes, this patient has a CHF and AFib history. The way when this case was presented to me, and Gerard and I are talking about it back and forth, I was thinking AFib started first. He got the rapid AFib, which then caused the left side heart failure to turn into pulmonary edema. Like, he already had CHF, so he's already got a weak, flabby left heart, left side, left ventricle. Now you add AFib onto that, which is now not a perfusing, it's not perfusing at 200, 220, where this paramedic found them. Is that going to set the CHF off, which then is going to make the pulmonary edema worse? That's my camp. I'm going to stay that fix the heart rate, fix the breathing, because you're still fixing the breathing in other routes, but I think fixing the heart rate was key in this. I don't think they would have gotten a lot better if they didn't fix the heart rate.
I don't
Your
think there would
thoughts?
have been nearly the success of this transport if they hadn't addressed the heart rate.
Yes.
Would the patient have been feeling better with this app breathing interventions? Yes. Undoubtedly they would have felt better, but I don't think it would have been nearly as positive a patient outcome, at least upon handoff at the ED, that it was without looking at, okay, what are we going to do to address the heart rate? How are we going to fix that? I think it was a cardiac driven issue.
And that's my thought process. I think the cardiac issue started the chain of events. Looking back at vital signs, before the metoprolol was hung, this guy was at 80% without the dex, without the second duo, without the metoprolol, with a blood pressure of 180 on 150 and a heart rate of 200. With the CPAP, the PEPA5, and the first duo neb, they increased 3% on their SpO2. I don't know without a heart rate change if that was going any higher.
So I actually think opposite of you. I think that it was a CHF thing that exacerbated the AFib, but I think that once you get to a certain point, you have to fix the heart rate. I think that the treatment was the same, and I'm agreeing with you guys, you have to fix the heart rate to fix this problem. What came first, the chicken or the egg? Like, I don't think at this point it matters. I agree with their treatment. And I said from the get-go, like, I wouldn't fix the heart rate just yet. Again, we've been talking about this for an hour. They were on scene for 10 minutes. Two different ball games. But, like, in my mind, it's CHF before it's the AFib, but I think that they were just to the tipping point that you can't get them back without fixing that heart rate.
Right.
So,
And I'm wondering
hard.
if this would have been different if that first AFib heart rate was like 150.
right.
If it wasn't 210, 200, what would have we seen if it was 150? Right? Like
Would they
maybe
have gone down that pathway if it was simply at 150, or would they have chalked that up to, his sympathetic system's in overdrive right now.
Right.
He's in fight or flight because he can't fucking breathe.
Right.
and that's it. Like,
so.
And again, I don't know if I, as a provider, would have even touched it at 150. I would have been in your camp. Let's fix the respiratory. Let's fix the CHF, because he's probably 150 because of the CHF.
Right.
Where at 200, I'm almost flipping gears where I'm thinking the AFib's what caused the CHF.
I mean, it totally could.
Who knows?
Yeah, you're never
and
going to
I
know.
think-
And I think the treatment plan was great.
Right.
Whether you think that it was CHF or AFib that caused all of this,
Yep.
I think the treatment plan worked.
So I'm curious, just with you thinking, maybe CHF driven, and what's the pathophysiology there? How is the CHF driving the AFib up?
So I think that with that heart failure and then the fluid overload, I think it was just too much.
Okay.
And I think that this is me thinking, and this is me creating a whole scenario in my head. Like, he's having shortness of breath. He's waiting to the point that you can't speak going into urgent care. Like, I think that if it was an AFib driven thing, it would have happened sooner. Now, I don't know, because I have no idea how long the symptoms have been going on. I don't know. Urgent care.
And
call
I don't-
urgent
and I
care.
don't either.
Right. Who knows?
Right.
But like, in my mind, he's 400 pounds. You know what I mean? He's a bigger guy, probably not the healthiest. Like, to me, I don't know. For some reason, I just think that CHF had happened first.
I mean, I didn't think of it that way. It makes sense. And again, we won't know,
Yeah,
and
you'll
I don't
never
think
know.
it
And it
matters.
doesn't- exactly.
It really
That's the thing.
doesn't matter. It's one of those like, I could
Cool.
beat myself
Yeah.
over. Right? Like I could beat myself. Which came first?
Leave that to the white coats to determine. You
They'll never
had
figure
the
it out.
patient outcome that was a
Right,
success.
and I'm with you. I
and
don't
even
think
then,
they'll ever figure it out.
I don't think you'll ever know what came first.
Right.
Just the fact that the fact that they treated both and they did ultimately fix that heart rate is what mattered.
So the only other thing that me looking at it from a medic provider standpoint, which, I'm going down the same route, except I think I would have done one thing different. And I want to see your guys' opinion. This paramedic decided to do CPAP, give the duoneb, figure out, okay, it's CHF, immediate 3 shots of nitro. I'm there with them. Give them metoprolol. Awesome. I'm there with them too. The Dex, awesome. The duoneb, awesome. Then they gave the second metoprolol treatment 15 minutes post the first. I don't know if I would have done that. I think I would have snuck in another. So the BP at that point in time was 150 systolic. I would have snuck in another spray of nitro right there.
Paste on.
We don't carry paste anymore. No. Years ago. And I hate paste.
Nitro.
I do too, but
It's
that-
sloppy and
that, I'm
disgusting
like,
and
just-
makes people pass out.
Nitro
No.
paste.
Sublingual, patch, paste, a bunch of different ways to administer it.
So
IV nitro.
I thought we were talking about some new fancy drug.
no.
Just nitro
IV
paste.
paste is old
That's
school.
old school.
So I think the only thing I think me as a provider, I would have snuck in another spray of nitro because our protocol at 150 is still one spray.
I'm with you on that.
Right? Up to 150-ish to like 180 is 2 sprays. Anything over 180 is 3 sprays. So I would have snuck in another 1 spray, give it 5 minutes, then
give
done the other
metoprolol.
metoprolol.
I'm with you on that.
Solely because I want more of that vasodilation so that fluid has somewhere to go. And you still have blood pressure to play with. And you're starting, a fluid bolus, minor, maintenance fluid. I can't really say it's a bolus. If they lose pressure with the
Right, you're
metoprolol,
ready.
I'm ready. I'm okay with that.
You can fix that.
But again, I don't think they did anything wrong. I think that's just an extra step that I would have thrown in there.
Yeah, I'm with you on that.
The only downside to that is you give everybody in the back of the ambulance a headache from the overspray. But
Meh.
I think I'm with you on
That's why I like paste.
giving. Yeah. It's old school, but you don't get the headache.
Right.
I think with the space that you have to play with in the blood pressure, that's certainly a viable thought to throw that in.
New EMT Kelsey, what are you thinking?
She's still marveling over the fact that nitro came in paste.
I'm thinking of like toothpaste in my head.
It's almost
How
the
do you even-
consistency.
kind of what it
of-
looks
How do you even like measure that? You just kind of
You put
So-
it on a little. There's a
Yeah, so there's
A film.
It comes with a piece of paper with a little measuring tape on it. If it's within this blood pressure, you put this amount of
You give
paste
an
on.
inch
So
of paste.
if it's right, so
yeah,
if
but like
it's
I could cake my paste on for like an inch, and you could put like very little across the inch.
again, this is why it's not there
Have you
anymore.
ever heard the phrase titrate to effect?
in the hospital. It's called a nursing dose.
Right. And again, I couldn't tell you how many people I've known personally when I was an EMT be going in there doing lead placement and stuff and then go through paste because the nurse
Well,
goes,
you're supposed to put the inch on and slap the thing on, put a tape over it. It doesn't move, and it's not exposed.
right. However,
Supposed to.
Come on, people.
people don't do what they're supposed to.
Jesus
This
Christ.
is the
I
planet
had,
Earth.
I had a
eat it.
paramedic
Just
pass
eat
out
it.
because of that once in the back of the ring with their patient. So it happens. So anything else to add? Kelsey, anything?
I want to say yay EMT for knowing those drugs because that's technically not something that they have to know. But like,
Yeah.
I mean, Emily and I'm gonna make drug cards with me on Friday.
I'm ready. I told you.
I know. I'm
got my
bringing my
colored pens
index
and everything.
cards. But I think that's a good thing, just like, because you do end up, I mean, I end up even on transports, like looking and be like, oh, I don't know this drug, and I write it down to figure out what it is later. And I think that's just a good thing that everybody should do, like,
Yeah.
no matter what level you're at. Because then you're going to have a patient that can't talk to you, and you're going to be like, I don't know what any of this is for. You could spend 15 minutes looking up new drugs, but if you don't know at least the common ones.
And that's it. Like there's definitely something to be said. You don't even have to know what this drug is. You just
What do they
know
take it for?
what it's for. I'm okay with that. Like knowing even the prefixes or the certain parts of the words.
Yeah.
Like the
where you're
laws
like,
or the...
right. You're like,
Statins,
oh, okay.
this sort of thing.
Statins usually end in this. Beta blockers typically end in this until the company throws in a, and then they go and say, go fuck yourself. And it's like, oh awesome. Thanks.
But I encourage
Why
you
did
guys
you change
to do
it?
that on every patient. And like,
Yes.
nobody will bitch more than me on a non-emergency transport. I promise. They're soul sucking. I get that. Look at the meds and go over it. There's gonna
Yeah.
be one you don't know. You will
We had one the
never
other day
know.
we didn't know.
I know. There was a few the other day that we had to look up. There's always new diabetic meds. You never fucking know what those are.
Yeah.
Just
And I
look at
swear the
everybody's
names
med
are
list.
getting more and more weird.
They're running out of them. That's the
Januvia.
I was just thinking that one.
Come from.
Yeah. Yep. Oh, it's crazy. So, if there's nothing else, we will see you. What month is next? March.
March.
Awesome.
Oh, it better be warm.
It
I just
won't
bought
be.
my Shamrock Shake.
It's not going to be warm.
It's not going to be warm.
This
If
EMT and
anything, they're
paramedic
gonna-
can get their Shamrock Shakes.
They're going to dump more snow on the Northeast, I'm sure. So, yay where we live. You're smiling and all
Got her
glory.
boots out
pouting.
today.
You got your what?
What?
Boots.
Your
did.
snow boots. Wow. Good for
First
you.
time I ever had snow boots in my life.
Oh man, so proud. of
You've
you.
lived in New York for how long?
I know,
My
seriously.
whole life.
But she's a Spaniard that doesn't know Spanish too.
All bets are off.
I mean, snow boots off the table.
What do
We
those
get
for?
6 feet of snow per year. Fuck snow boots.
Walk out in
I
your
wear
flip-flops.
slippers.
Crocs.
Flip-flops.
It's Crocs.
Just put them in four-wheel drive. That's all you gotta do. You just gotta flip the thing in the back.
The adventure strap goes back, 4-wheel drive, it's all
Oh,
fine.
it's so weird. I don't know how people wear those things.
I love my Crocs.
I love them.
I don't own a pair of
I can't
sandals.
rock the Crocs.
I don't own a pair of sandals. So I,
I rock the Crocs and socks. Firm believer.
yeah, it's not. Is that like female mandals? Is that like famdals? Femdals?
I don't know. Do you wear the black socks?
This
with
is why
them?
we
I
can't.
wear my
record.
Carhartt socks.
Okay.
I wear my Carhartt socks.
Your Carhartt socks.
Carhartt socks and
I
Crocs.
was gonna say like. It's,
This is going terribly. I'm going to end it right here. Guys,
do.
we'll see you in February. Stay safe.
We'll see you
And
in March.
Damn it!
It is February.
Is this the mid-month?
This is the mid-month.
Like yesterday's
So we will-
Valentine's Day.
It will be February when it goes out.
No.
Or is this the March mid-month?
This is February 15th.
So he's saying goodbye, I'll see you in March, but he said I'll see you in February.
Right.
Yeah, but we will see. This will go out in February, right?
Correct, but I'm saying I'll see you.
I know, it's
future.
not February. I get it. I'm just trying to plan when this came out.
Like 4 days from now. Okay.
Day after Valentine's Day.
So anywho,
It's the future.
I'm glad none of this will be in there. Because people will be like, what the fuck? They just lost their damn mind.
right there.
It's 10 o'clock. What do you want from me?
Good gravy. All right, guys, we'll see you in March. Thank you for listening. Again, if you want to send Gerard a happy miss you message, please do info@medicmaterials.com or send me a Facebook message at medicmaterials.edu. I will forward everything to him. He loves memes, so create a great meme, and I will send it right to him. Take care. Stay safe.
Oh, nuts. Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at medicmaterials.edu or watch our weekly instructional videos on the Medic Materials YouTube channel.